Hello, and thank you so much for joining us today for the webinar New Materials in Soft and Hard Tissue Preservation, First Experience with collacone, max and mucoderm punch. We would like to thank Dr. Dávid Botond Hangyási for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself.
Hello. Hello, everybody. I hope you see me and you see everything. So it's a pleasure to be here. Thank you for the invitation and thank you for coming here today. This is my second lecture on the botiss Academy at these webinars. And believe me, it's a really interesting feeling to sit here with you now. So we will talk about new materials and in socket preservation, mainly collacone max and mucoderm punch. And I just would like to show you that this is what I see of you now. So this is my visible audience today. So it's really interesting to talk to my computer. So that's why I will borrow a little audience from AC/DC today. So let's say this is you. So welcome. I'm happy that you are here today, and I know that some people are still coming because dentists are working so late and this lecture is a little bit early today. So we will wait a little bit, and till we wait, I will tell you what we are talking about today. We will talk a little bit about the hopeless teeth and actually the socket we would like to preserve. So when do we say that something is hopeless? Let's talk a little bit about that till we are waiting for the others now. I would like to show you a little story. This is a dentist and the patient, and this is the first meeting. And sometimes really unexpected things happen. So the patient sits in your office, you look into the mouth and you see that the teeth are moving, and you know that there are hopeless things. So you can have the same feeling like here, not expecting anything positive. So when do we say that something is hopeless? I think that this situation here, you see, is something like this situation here. Actually, he is Barnabor, he's a Hungarian judo player, one of my friends. So this is the outcome, and of course, if we are talking about the hopeless teeth, we have a classification. We can classify when do we say that a tooth is hopeless. So this is the individual tooth prognosis, and we say that if we don't have enough attachment to maintain health, comfort, and function, then we have a hopeless prognosis. Usually we have to extract the tooth. So what's happening? We extract the tooth and we will have a socket. This is the socket. We have some bone and we have soft tissue around. And we would like to preserve this bone and we would like to avoid to have a collapse of the soft tissue. So actually this is what we are talking today about. This is the situation. You see the bone around that what we would like to avoid to resorb. So we are talking about the extraction socket, and what is happening in the extraction socket today. We know that in that very moment when you extract the tooth, the bleed is coming. So you will have a blood clot formation, and we have to protect the blood clot because this is the starting point of the regeneration. So in the first 24 hours, in the first 3 days, we have some bleeding, we will have the blood clot, we would like to stabilize the blood clot, and there's going to be a formation of a fibrin layer, and all pathways of the clotting cascade will be activated. What if we cannot protect the blood clot? Why is that so important for us? We can have some complications, and you know, an infected socket or maybe smoking can be a problem, and if the blood clot fades, we will have really severe symptoms for the patient, severe pain, and we see a socket which looks like an empty socket. We don't have any more bleeding. So the nerves are exposed and we have to do some therapy. We do excochleation. We want to have new bleeding. And sometimes we are rinsing, we give some painkillers, and sometimes also antibiotics are needed. So we don't want to have a dry socket and alveolar osteitis. We would like to avoid it. And for that reason, we can do several things. So on one hand, we would like to reduce or stop the resorption of the buccal bone and the collapse of the soft tissue. On the other hand, we don't want to have a dry socket. But sometimes, if we are using grafts for one reason, sometimes we fail. Like in this case, for example, the soft tissue graft can fail, and then the graft materials can be exposed, and maybe we can have a dry socket. We have to do an excochleation, some anti-infective therapy. So we have to deal with this situation. So usually in a natural healing process, what's happening in the socket? In the first week, we have a temporary scaffold, and the epithelium tries to grow above the socket. And on the other hand, we have an active crestal resorption already. And inside the socket, we have some angiogenesis. So within 1 week, already we have a provisional matrix. And in the second week, some mineralizing process starts from the intact socket walls and the formation of a new woven bone, actually. But on the same time, the new blood vessels are coming and going to the center of the clot, and the osteoclastic resorption is going on further, so we still have a fast resorption. In the third week, we have a very, very quick resorption of the bundle bone. So the socket is losing its shape, and inside we have a granulation tissue with poorly calcified bone. And on the third or fourth week, we already have a almost complete healing of the surface of the wound. So it's epithelialized. So the soft tissue healing is already getting to the final stage, but the bone healing is going on further and further. Up to 4 to 6 months, we still can have changes in the volume, still can have some resorption. Resorption continues actually for 2 years, but not so hard anymore. In the first 4 to 6 months, we have a bigger volume of change. So now we know that the natural healing of the socket is associated with bone resorption. So what are the stages of the socket healing? In the first days, we have the blood clot formation, then fibroblasts reorganize the blood clot in the next days, and a provisional connective tissue matrix is replaced in the first 2 to 3 weeks, and osseous remodeling is going up to 6 weeks and up to half year. We know that the bundle bone is very important because if we lose it, and this is in a really tight contact with the periodontal ligaments. So usually when we extract a tooth, we lose this bundle bone. And if we lose the bone, we will have less bone. We can have aesthetic problems, and maybe we can have complications when we would like to place an implant. So the reduced ridge is not really good for the later procedures. And maybe we will have to do some additional augmentation procedures in the future. So in case we have hopeless teeth, we try to stop or reduce the resorption. Because we would like to improve the aesthetic outcome, we don't want to do additional procedures for augmentation. We would like to have a stable implant installation and prevent the complication like a dry socket or any other infections. And there is one more thing which is very, very important. We would like to reestablish the health of the patient as soon as possible, and we would like to reduce the time of healing and the regeneration. I'm sure you all know these different patterns of the resorption in the mandibular and in the maxillary regions, in the anterior and in the posterior zone. So maybe depending on the site, we choose one or the other solution for the protection of the site. When do we have to extract the tooth? And this question is about timing now. So about timing, we can, if we would like to place, for example, an implant, we can go on immediate, early, or delayed implant placement. And of course, we have some really good guidelines from the ITI treatment guidelines for the classification for this kind of procedures. And we have a risk analysis table also, and these can help us to decide. But a lot depends on which procedure we are more familiar with. So for example, if you have a high-risk patient, you have infection at the implant site, or you have a thin tissue biotype, maybe more likely you choose not to place an immediate implant, but go on an early or delayed implant placement. But it's actually up to you, it's up to the dentist, which one he's choosing. So now we are talking about alveolar ridge preservation. Actually, usually we place something into the socket, some grafting materials. This can be autologous graft, autogenous graft. It can be a xenograft, for example. So we can use some bone substitutes, or we can use synthetic alloplastic materials, for example, like maxresorb. And we know if we are using particulated grafting materials, it is suggested to use a membrane to cover it. The bigger augmentation we do, the more likely it's suggested to use resorbable or non-resorbable membranes. There are other theories also. Some suggest to use only membranes to keep up the volume without bone grafting materials. And of course, there is a philosophy about if we have to do a flap surgery or avoid to do a flap surgery. If you have an additional flap elevation, you will have an additional bone resorption also. So we try to avoid to have additional resorption. Maybe we don't elevate the flap. There is one more very important thing that if you read the literature, you know that there is no one universal solution, no one universal bone grafting material, not even a surgical technique, which would be supposed to be the best on the market for socket preservation. So we have to decide it ourselves, which kind of solution, which kind of technique, which kind of material we would like to use, and we would like to adapt it to our particular case. From the atraumatic extraction to orthodontic extrusion, different kind of GBR procedures, we can talk about ridge preservation with soft tissue grafts described by Kobi Landsberg, for example. And there are some different theories about the immediate implant placement also, when we can do it, if we do it, should we fill up the gap between the implant and the buccal plate or not. And we can use tissue engineering approaches, and there is one very fancy thing nowadays, these partial extraction therapies. You may know the root submergence technique, the Pontic shield and the socket shield described by Howard Gluckman last year. These are more and more famous solutions nowadays. So there is a huge range, and you can decide which one to use. Today we will talk about basic solutions, basic classification, and I will show you two materials which is new on the market, but actually it's up to you with which kind of solution you choose. First of all, we have to know the whole plan, what we would like to do. Do we have a bridge? Do we would like to place an implant to the extraction site, and only then we can decide what kind of material and solution to choose. Of course, everything starts then with the defect examination. So what are we doing now? We are fighting for the bone and we are fighting for the soft tissue in the same time. So sometimes we need bone grafting materials, maybe autologous bone or some substitutes. And sometimes we need mucosal grafts, soft tissue grafts. Maybe we would like to add some buccal volume to the soft tissue. Maybe we would like to cover the extraction socket. And we can use these things in combination and try to guide the healing of the socket. So maybe this is a kind of guided bone regeneration also. So this is a question I mentioned before. Do we do it with or without flap elevation? I just would like to show you a case with no flap elevation. After extraction, the implant was placed. You see that there is a gap between the implant and the buccal plate. And you can decide if you add something or not. In such situations, I usually add some bovine bone grafting materials, which is a non-resorbable material. These small cerabone granules can keep up the volume to the gap, and even if you have a thin buccal plate and you have a resorption, this non-resorbable material keeps up this volume, and you can have a new bone formation between the particles. So you can preserve some volume. Maybe you cannot stop the resorption, but you can reduce the amount of the resorption. You can cover it with a collagen membrane. You can cover it with free soft tissue graft, like it has been described by Kobe. So these are really good solutions. Or on the other hand, sometimes you think that you have to do a flap elevation. Of course, in a lot of cases we have a CTs, so we already have some impression about the thickness of the bone, and we can do some bone sanding also. And if we know that we have a thinner bone plate, like in this particular case here, and I knew that I would like to protect it, I would like to do some augmentation. So it was an immediate implant case. I decided to fill up the gap, and because I had a thinner buccal plate, I did some lateral contour augmentation also on the outside of the bony envelope. So now I was raising a small flap. This is the bovine granules around the implant, and some granules are also outer of the bony envelope, and it was covered by a adjacent collagen membrane. In such situations, you can decide if you do an immediate crown or you want to close. In this particular case, I was closing the flap, and we all know if we do the re-entry, we will have to deal with the soft tissue. We will have to do some soft tissue management. So, for example, in this case, I was using a CTG, a connective tissue graft, and I was forming the tissues. And if the implant is in the desired position, in the ideal position, and if you have enough tissue around the implant, you see that with this kind of procedure, we were able to protect the interdental bony peak also. So we have a support for the papilla, and on the same time, we have space for the connective tissue attachment, and we have space for the sulcus, epithelial sulcus also. This is a 2 years post-op X-ray, and you see that we have thick enough bone, and this is stable over time. And if you see the contralateral side, you see that maybe we also have a small gain. So on the one hand, somewhere we lose some bone, of course, but with this kind of procedure, we have a small gain also. So this tissue can be stable over time. With this lateral contour augmentation technique, we can be predictable. But we know we were using a non-resorbable bovine bone grafting material. So actually, this is not true real regeneration. This is a kind of reconstruction. We have those particles there, and between the spaces, we have the newly formed bone. And if you see at these pictures, you see that we have a little bit thicker soft tissue. not really the same outlook, but the color, the texture, the contour of the tissue is nice. And this is a thick tissue, so we can rely on this tissue. We can hope that it can be stable on the long term. And of course, we all would like to have long-term results. That's why we are choosing these kind of procedures. Which procedures? So how to decide which procedure to use? Of course, there is a classification for the socket also, and if we would like to decide which kind of procedure to use, we have to classify the socket. We check for the bone, we look for the soft tissue and any signs of inflammation, and we know that the quality of the socket depends on the presence or absence of the buccal hardened soft tissues. So there is a classification for Alien and colleagues, and he says we could classify three main types of the socket. In the first one, we have intact buccal plate, intact soft tissue. In the second type of the socket, the buccal plate is missing partially or everything is missing, but the soft tissue is present. And in the third type, both the buccal plate and both the soft tissue is missing. And we can subcategorize it a little bit. And they also have a protocol for the preservation. This is a suggestion from them, a proposal. So you see that you can say that maybe you have a 1A subcategory for the socket with a thick biotype in the posterior region. If you have a buccal plate, maybe you don't even have to place any graft. In another situation, let's say this is 1B, you have a thick biotype but anterior tooth with buccal plate, maybe you will choose a collagen dressing. In a 1C, it can be a thick or thin biotype patient with buccal plate, but thinner buccal plate. So maybe you already need some bone grafting material. And of course, in the second type of the socket, if the bone is missing, you need a bone graft and you need a membrane to keep up the volume and the form, to do some guided regeneration. And in the third, if you miss bone and you miss soft tissue also, you need the bone grafting material with a membrane. Maybe you can use some biologic agent also. And if you have less than 2 mm of keratinized tissue, you will need the soft tissue graft in the same stage or a later stage of the therapy. So this is a protocol you can follow. Of course, there are different protocols also available. I think this is a good one. Let's see one sample for this first type of the socket. This is the extraction of the tooth, and you see this is a thick biotype posterior tooth. We have the buccal plate, and if we follow the protocol, no graft is necessary. We go back for an early implant placement 8 weeks later, and you see the stable implant placement is possible. We have to do a small gap augmentation. We did it with the cerabone in this case, but you can also do it with the synthetic maxresorb. So this is the type 1A socket, and for me it's a little bit questionable if a graft is necessary or not, because you know that we can have a resorption in a horizontal direction, we can have a vertical direction from the occlusal plane, and we can have vertical from the sinus also. So maybe it works to place something into the socket, but if you place something inside, you won't have a bone heal in 8 weeks. You cannot go for an early implant placement. You can only go for a delayed one. Let's have a case for 1B type of the socket. This is a thick biotype patient, anterior tooth, buccal plate, soft tissue is present and intact, but for any reason you decide not to place your implant immediately. It can happen, maybe you have an infection like we had in this case, and you decide to wait. And we only were using a collagen dressing and we were waiting for 8 weeks. we went back to the case 8 weeks later, you see that there is a change in the volume, there is a horizontal loss of the bone, but we have a nice healing, and we had enough bone for implant placement. Later on, we had to do some soft tissue management around the implant to have a nice soft tissue around the crown. So this is the second type, and if we are following this kind of protocol, a collagen dressing is recommended. Let's see another case. This is a thick biotype patient. This is 1C. Now we have a thinner buccal plate, and you see the diameter of the tooth was a little bit bigger. So we place the implant, we have a bigger space between the implant and the buccal plate, and the buccal plate is running a little bit out of the bony envelope. So if we lose this bone, we will have a bigger change in the aesthetics. Maybe we have a collapse of the soft tissue. Bone graft is recommended. In this particular case, we did a GBR procedure. We went out of the bony envelope and we were doing a lateral contour augmentation. And you see the difference between these two cases, the two situations, that a few months later we had bone gain. Yes, this is reconstruction. This is bovine bone, non-resorbable bovine bone with newly developed bone of the patient. But this is stable and we can keep up the contour and we have less resorption. So the delayed implant placement was possible. If we go back for an early implant placement, we lose all the substitute we were using. So this is the third type of the type 1 sockets. Let's see another case. This is 1C again. This is the same case I showed you before. So again, we have a thinner buccal plate and we were doing this lateral contour augmentation I was talking about. And now on the X-ray, you see how much gain, how much preservation we have in the end. So I think this is a reliable solution. Let's see a case for the type 2 socket. We are extracting the teeth, and we know it from the CT that we have some fenestration defect. So the buccal plate is partially missing. This is a fenestration. So bone graft and membrane is recommended. We have to do some guided bone regeneration in a case like this. I show you another case for type 2 defect. Let's say this is 2B. The first one was the fenestration, and this is like a dehiscence defect, so the coronally part third of the buccal plate is missing. So in this particular case, you see that the coronal third of the buccal plate was missing, and we have to use a bone graft and the membrane also to augment this site. In the third type of the socket, we are missing not only the bone, but even some soft tissue, more or less soft tissue. So you can use a bone graft, a membrane, maybe a biologic agent is recommended. In this particular case, we were not closing the flap. We were using a gingival former. And this is the site a few months later. You see that we have some changes, we have some resorption or collapse, but we still have a nice volume of the soft tissue. And now we can form the tissue around the crown. And if you check the X-ray, you see that we have the bony peaks. We could preserve the bony peaks, and we have a nice bone heal around the implant. So let's see one more case. Let's say this is 3B. In this situation, again, we will have some loss of the buccal plate, and we lost the soft tissue also. You see we have less than 2 millimeters of keratinized tissue. In this situation, we use a bone graft, a membrane. You can use a biologic agent, but for sure you will like to have some soft tissue augmentation also to have a nice outcome. So this is the situation. This is the defect. We fill it up, place the implant, fill it up, and then we use a soft tissue substitute. In this particular case, I was not using CTG, but we were using mucoderm. So mucoderm is one of the materials we will talk about. Not this form, but another one, but the material is the same. The form of the material is different because the other one is a round form, a pouch, and this one is usually used for soft tissue augmentation or teeth and implants. I can tell you that I'm using this kind of material for 6 years now. We were treating more than 500 recession type defects with this kind of material. In that situation, you use it covered. Today we will talk about if we can use it uncovered or not. So I would say that it's easy to work with, and for me it's a really reliable material. For me it's not that new actually. Like we say that mucoderm punch is a new material, new for that indication what we are talking about today. So this is the outcome. We have a stable bone, we have stable soft tissue around the implant and the tooth and the crown. So we can follow this kind of classification and protocol from Alien and colleagues. Of course, we know other solutions and we can choose other solutions also. And we have to do a decision which material to use. So if we would like to fill up a gap, fill up a socket, we know we need some bone. We can use autologous bone, we can use autogenous bone, we can use cyanogenic bone. This one, what you see now on the video, this is cerabone, and this is collecting the blood from the autologous bone. This is very important because this is what we are waiting from this kind of material. Actually, you see that the bone is going inside to this space, the cells are going inside, the vessels will grow inside, and we will have newly forming bone here in this space between the granules. This is a reconstruction. This is not real true regeneration because this is a non-resorbable material. But this is hydrophile enough, this is containing the volume, this is giving a scaffold for the newly forming bone. This is very important for us if we would like to do a procedure like this. So we will replace the lost bone matrix. If you decide to use a synthetic one, which is resorbable, then mainly with time, it's during the resorption, you can have a newly forming bone instead of the synthetic granules, or you can have some changes, late changes in the volume. It depends the case. So actually, we know bovine bone has got about 20 years of history in dental implantology, and we have long-term data with it. We can rely on it. So we will talk about a little bit with maxresorb, which is a synthetic biphasic calcium phosphate, and then we have a controlled resorption. So we know that there will be a resorption over time. We know this material from periodontal surgery, like we know mucoderm from periodontal surgery, and today we will talk about collacone max, which is actually maxresorb mixed with collagen, and we will cover it with mucoderm. So more or less, we talk about the same materials, but in a different form. So we know now that we can reduce the changes, the dimensional changes of the bone. We cannot prevent the resorption. We cannot stop the resorption. Sorry. So we still expect a loss in width and in height. But we know some solutions which are more or less predictable. And there was a study. They were using xenograft materials, so bovine bone like cerabone, for example, versus an empty extraction socket. And of course, if you don't use the bone filler, you will have a greater horizontal resorption. We actually know that already. And we know if the socket is grafted, we have highly mineralized and well structured bone, newly forming bone. So we know the difference between the empty socket and between the socket we treat with these kind of materials. We know these materials from horizontal ridge augmentation, from guided bone regeneration, and also we know some histological outcomes. We had our own cases also, but it's written also in the literature that we know that there is a newly formed bone around the particles surrounding the particles. So there is a new bone formation, but the particles stay there over time. So, but the lecture today, and this is the first slide again. So we said that we would like to talk a little bit about new materials, the collacone max and the mucoderm punch. So these are actually not new products. This is a new form of these products. So we have some we have some experience already with these kind of materials, but not in this form. So what are we talking about? Collacone max is a calcium phosphate containing collagen cone. This is it. You extract the tooth and you push this cone into the extraction socket. This is a very clear and clever theory. This is a good idea, actually. The question, is it real? Can that work or not? So we had some cases. We were using this cone, which is a mixture of the bone particles and the collagen. We had a nice clinical healing, and we could do delayed implant placement, stable implant positioning. So in which situation could we use this kind of material? I would say that only in the type 1 socket would be recommended up to our knowledge now. So I would say that 1A, 1B, 1C, instead of the protocol I showed, we can think about to use collacone max. It can be an option. For example, on the maxillary posterior side, if you push a cone like this inside, maybe you will have less resorption from the direction of the sinus, or horizontally, or vertically from the occlusal plane. So in every situation, there can be an indication for it, but we have to know that then we don't go for an early implant placement, but for a delayed one. So we have to decide which one to use. So are you happy with this idea? Is there anybody who is happy with this? Because I see you maybe you are happy. You are the best audience I can wait for today. So before this collacone max came on the market, we were using these kind of materials actually separated. Maxresorb granules can be placed into the socket, and we covered it with collagens. And we had some histological samples also, and we had a nice clinical healing. So this is a place for a delayed implant placement. We did a preservation with maxresorb, with this synthetic bone grafting material, and we covered it with a fleece. And this bone was stable, and you see that it was possible to do stable implant placement. And we know it also from the literature that it's better to use it combined with a membrane, and we can have a greater bone growth where we use these kind of resorbable materials. And we also know from an EAO consensus conference that what I said already now, that we can reduce the resorption, so we are efficient enough, and maybe we can reduce the need for a further augmentation also. So this is the situation a little bit later when we do the soft tissue management, and these are the final rounds in this situation. So this is a new form of the material, and there is the question how to use it actually. I would like to show you two of our early cases because we had some really important experience with this kind of material. I already showed you this case. This is the 2B. So the coronal part of the the coronal part of the buccal plate was missing. This is not an intact socket. So now I told you that now I think this is not the perfect indication for this kind of material. But we extracted the tooth, and the idea, the theory, you only have to push this cone inside. This is flexible, it's easy to push inside, but now you already see the difference between the size of the radix of the tooth and the graft. So in this particular case, we extracted the tooth, we cleaned the socket, and we were pushing the graft inside, and we were holding it in its position with a Maryland bridge, with a Pontic bridge, because we wanted to form the soft tissues at the same time. Already now you see that there is a small collapse of the soft tissue. So there are some changes. And when we go back after 3 to 4 months, we see some granules. So now we see there is no newly formed bone between these granules. And we remove these granules, and what do we see? That actually the buccal plate is prevented. There is not a big resorption, but there was no bone fill. Maybe we went back too early. Maybe the problem was that it was not an intact buccal plate and there was some connective tissue ingrowth. So we would say that it was a bad indication for this kind of material. It was possible to place the implant. It was possible to do a second augmentation in the same stage of the implant placement, but we had to do a bigger additional GBR procedure in this situation. And if you check the situation when we were managing the soft tissues, you see that we can form the soft tissues, we have keratinized tissue, but there is a change, there is a collapse of the soft tissue, and it's a little bit different from the neighboring. So I would say that in this particular case, we had reabsorption, we had the dimensional changes. Maybe it was not the best indication for this kind of material because a GBR procedure was still needed. I would like to show you another case, and in this situation we were placing the graft inside, and the graft was a little bit too big maybe, because now you see that the mucoderm pouch is a little bit above or in the level of the gingiva. But we were suturing it there, it collected the blood, it looked nicely, but it was not possible for the vessels to grow inside the mucoderm pouch, so we lost the mucoderm pouch. And the granules were exposed. So actually, this is not what we were waiting for. Of course, it can happen with autologous soft tissue graft also. But let's say it's a little bit complication we had to manage. But I would say it was a lack of biological thinking, actually, because we were not thinking about the principles of guided bone regeneration. What do I mean? I say that this is a cone, and we are suggested to push the cone inside the socket. But if you push it inside and this is too big for the socket, then you will have some granules above the bone in the level of the gingiva. And we don't need bone substitute in the level of the gingiva because we cannot have bone regeneration there. but if it's exposed, we can have an infection or we can lose some granules. We won't have the guided bone regeneration as an outcome. So we can have some complications. And if it's so high and the soft tissue punch is above that, then the soft tissue punch is not connecting to a good blood supply, not connected to a good blood supply, and this is a little bit higher than the margin than the gingiva. So that's the reason why we can lose these kind of grafts. So what would I say? That we have to stay with the soft tissue substitute below the level of the gingiva, close to the bone for a better blood supply. We were collecting our ideas, we were thinking about, and together with botiss, we were working on a protocol how to use this kind of materials in a connection. So now we would say, if we would like to use collacone max and mucoderm punch together, we have to do an atraumatic tooth extraction, a flapless design. We have to clean the socket carefully. Of course, we have to check the defect if it's intact. And then we have to measure the depths of the socket. We cut the collacone max cone to the desired size. It should be 1 to 2 millimeter below the bone level. So we push it inside below the bone level, like you see it on this picture, and then it's very important that we don't press it. We don't have to overfill it, because if you press it, the granules get too close to each other, and you don't have the space for the blood, for the cells, for the vessels, for the newly forming bone. And then you can have a dry socket syndrome. So you don't push it. You cut it for the size, you place it inside below the bone level, and then it can collect the blood as you see it on the video before. The next step can be a free gingival graft, or you can apply a mucoderm punch, suture it to the sides, or we will show you a third solution. You can use a rehydrated, you have to rehydrate the mucoderm, like we do it in this situation. And after 5 to 10 minutes, you can place it into the site. You place it a little bit below the marginal gingiva and close to the bone. So you see it on this picture, on the third picture. The cone is below the bone level, and the soft tissue punch, the collagen is sitting on the bone because there is a good blood supply. This is below the marginal level. So this is close to the GBR principle because the bone grafting material is closed by a collagen. This is a thicker collagen matrix. It can collect the blood, the vessels can grow inside, and then you can have a nice soft tissue healing. So I would like to show you some cases. This is the extraction site, the cone placed inside below the bone level. It's easy to fit it inside. Then after the rehydration procedure, the mucoderm punch is placed above, but this is still below the gingival level. And in this particular case, we hold it in its position with the pontic bridge. And after a few months, you see that we don't have a big change. The tissues are stable, and we can use this kind of materials in this way also. Let me show you another case. This is the second case. This is the extraction site. We can cut with scissors, we can apply with tweezers, and we know that the collagenous phase provides biological signals to promote the wound healing, and the phosphate, the biphasic calcium phosphate, is giving the volume stability, and on the long term, it's giving a complete resorption in a controlled way. So this is the mucoderm punch above the the graft, you see that we have some changes. It's recommended to go back after 4 to 6 months if you would like to have a better bone healing. I usually go back after 3 to 4 months, and I know that I will find some particles which is not integrated. So maybe I have to remove some granules from here, but I have a nice form of the bone and the bone healing in the apical part, and it's already uh, possible to do a stable insertion of the implant in the regenerated side. Here you see that we have the nice buccal plate also. We have to do some small gap augmentation with cerabone or maxresorb. But of course, time is important. We don't want to wait up to 6 or 8 months for the complete regeneration. Maybe we do a small augmentation again, but not a big GBR procedure. So this is one more case. This is the extraction site. Again, we are measuring the depths and we are cutting the graft to the desired size. This is below the bone level now. This is the cutted mucoderm punch and hydrated mucoderm punch. This is the below the gingival level, close to the bone. And after a few months, when you go back and place the implant, you see the buccal bone is thick enough. We have enough buccal bone, and we have a nicely regenerated bone. And this is not a reconstruction, actually, this is a regeneration because this is a resorbable material. So this is the sign when we start with the soft tissue management. One more case is coming. This is an early case again. You see, this is not an intact socket, but the palatinal part is intact actually. So we clean the socket and we place the graft into the intact socket. This is the way we place it inside, and we place some granules and mainly collagen above the buccal side. And then we are waiting again. Here you see the suturing soon. So we can do some cross the mattress sutures, but I skip it now. It looks like this. And we go back to the place after 4 months. 4 months later, you see that we have a nice keratinized tissue. We would like to know what kind of bone we have. It's maybe a little bit early to go back to the site. You see that we have some granules at the palatinal and at the buccal sites, but in the apical part, we have a nice bone fill. So in the coronal part, we didn't even lose the height of the vertical bone. We see the septum in the same position. We have to move some granules, but you see that we have a nice base for the bone. We can place the implant and have to do a small contour augmentation, not a big procedure. Then we have to form the soft tissues. And this is 1.5 years later. We have stable position for the implants, and what you see that even the dimension from the sinus is prevented. So we didn't have a big resorption from the direction of the sinus. In these situations, we usually took biopsies also. So we saw parts of the biomaterial in direct contact to the connective tissue. It's capable for giving rise to bone, cartilage, or fat tissue. On the other biopsy, we can see some new bone islands with the collagen fibrins and, of course, all the lamellar bone particles also. A few cases are left only. This is another case. We have separated the roots, again measuring. We can cut the cone to the desired form. This is a new product on the market. We don't have long-term results, but already some articles are available. If literature is, of course, it's important for everybody, so you can read about these kind of materials a little bit. So again, the cone is in the site, the mucoderm graft in the site. You see we have a nice um, keratinized tissue, some changes in the volume. This is the site when we go back after a few months and the implant is in its position. We have a nice wide enough bone and a stable implant placement. So I told you that this kind of material is mainly recommended for single extraction sites with intact bone. I show you another case now. In this particular case, we had multiple extraction sites, but we had thick enough bone around and we had thick interdental bone also. So we were placing the grafts, we were suturing the mucoderm grafts above, and this is the site 4 months later. Some granules are removed. Implant positioning is easy, and really a small gap or contour augmentation was needed only. And plus one clinical case. This is a little bit different. We were doing the same multiple extraction therapy. We had thick interradicular bone, and in this particular case, I was not covering with mucoderm pouch, but I was covering with this new permanent PTFE membrane from botiss. And you see that after 3 or 4 months, you have a really nice bone fill, and still the interdental bone, the interradicular bone is still there, so we didn't have a loss. The CT looks nice. We did a navigated surgery, and when we are placing the implant, then you will see that even this interradicular bone is there. So there is no resorption. I think that we could reduce the resorption, but of course this is a thick tissue biotype. We had a nice healing. So today we were talking about the extraction circuit. We were talking about the classification. We know that the physiologic processes cannot be prevented. We will have some resorption, but this is a realistic goal that we would like to minimize this resorption. So we cannot stop it, but reduce it. Because we would like to improve the aesthetic outcome. We don't want to do additional big augmentative procedures. We would like to have stable implant installations, and we would like to prevent complications and, of course, reduce the time of healing and the regeneration. I would say that synthetic biomaterials are, so we don't have long-term outcomes, we don't have long-term evidence, but maybe synthetic materials will be the future. For these two products, I could say collacone max is a synthetic one, mucoderm is a serogenic soft tissue graft. So this collacone max is keeping the volume, maintains space for the healing, and both of the materials is easy for handling, and we can have a complete resorption. So there is space for real regeneration, and they say that the resorption is somehow controlled because we know the time of the resorption. So I hope you are happy. I see you are really happy. You are the best audience I could have today. And it was really nice to be here with you. I really enjoyed it. Thank you very much for coming and for the invitation. And I hope to see you soon or see you soon in the, what kind of room is it? So if you have any questions, please ask me. Thank you very much. Thank you, Kelly. You are the best audience today. If you have any questions, please feel free to ask. Maybe I can answer it. But if you don't know your questions now, you can find me on email or on Facebook, and you can. Hello, Rami, Dania. So the question, which kind of implant I'm using, from Anwar, I would say that I'm using different kind of implants. For example, Straumann, Megagen, Ankylos are in the presentation. There is a Hungarian implant system also. Thank you, thank you. So Remy, if there is an advantage of using collacone max over cerabone, I would say that this time, based on my experience, I cannot answer this question up to now yet, because you know that cerabone and bovine bone has got a long-term outcome, and it has got a real history in dental implantology. But I would say that this theory is very interesting, and in the type 1 defects, in intact defects, it can work. So after a few months, if I go back to the place, then I see that we have a nice nice bone fill. There are some granules I have to remove, but don't there is no need for big augmentation again usually. And what I see, even if I have to remove the granules, usually the buccal plate and the original form of the socket is there, more or less. Of course, we need more experience. Um, that's my answer for this question. Uh, Sorry if I don't say the names in the right way, but Sharif asked me if I use PRF. I don't have experience with PRF, sorry. If I prefer this product over autogenous bone, I would say that autogenous bone is a autogenous. Yeah, so if you use autologous bone, that has got a fast resorption time. If you would like to use allogenic bone, that's a good choice. Also, in our country, allogenic bone is not available, so I don't have experience with it. We can only choose this xenogenic or synthetic or autologous bone. So, collacone max mainly for socket preservation, Remy. I would say that actually collacone max is there on the market for only this indication. So if you ask the company, they would say that this is there because of socket preservation only. Hello, Kai. When do you prefer collacone max and when immediate implant placement after tooth extraction? So I would say that it depends on the surgeon and the experience of the surgeon. But I would say that if you follow the ITI treatment guidelines, that's a very, very good um, decision. You can do the risk analysis, of course. In my opinion, if I have a good containing defect and there is a stable implant placement, I would prefer immediate implant placement. With such implants, I can place a little bit deeper, these bone level implants, with a rough platform, and would do an augmentation. And in such situations, I would do a small lateral contour augmentation. Also, you saw it in my videos that then I have some more gain. Maybe that's not regeneration but reconstruction, but that's stable tissue over time. So I would say that immediate implant placement is a good thing, but I don't do the immediate loading in most of the cases. If we would have an infection, if we are afraid of the soft tissue, if we have very, very thin tissue, if we are out of the bony envelope, and so on, or maybe granulating tissue were there, I would say that then I would like to do the preservation. I'm afraid of doing the implant placement, and then I would use collacone box. I hope I was answering the questions up to now, and I'm happy that I see some people I know for from my international courses. So it's nice that you are here. Thank you, Rami. So I don't know if we have any more questions. I answered it before that I'm not using PRF yet. I see that's a very interesting hot topic nowadays. I think there is potential in it, but I don't have real experience with it, so I was only using a few times. Thank you, Val, once again. I think it's a really interesting topic. If you read the literature, I'm not sure you will find real protocols, real suggestions. I think this kind of protocol can be followed, but the ideas behind the partial extraction therapy, for example, those are very interesting also. But my opinion is that both the partial extraction therapy, we need long-term follow-up and long-term experience to be able to tell the right decision. Thank you very much for the help and for the invitation. And it was really nice to be here with you.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.